Hi, this is Doc Ina and welcome to my lecture on basic concepts on intrapartum fetal heart rate monitoring. To download my lecture deck, please go to my WordPress site, Docina Obigaine. Here are the references for this lecture. And this is the outline of my lecture. So, intrapartum fetal heart rate monitoring is a modality intended to determine if a fetus is well oxygenated. The rationale for intrapartum fetal heart rate monitoring is that identification of fetal heart rate changes potentially associated with inadequate fetal oxygenation may enable timely intervention to reduce the likelihood of hypoxic injury or death of the fetus. There are two methods by which we can do fetal heart rate monitoring, and this is through intermittent auscultation or continuous electronic fetal heart rate monitoring. Now, for this lecture, we will focus more on continuous electronic fetal heart rate monitoring. Now, the picture on the left shows us an example of how we do intermittent fetal heart rate monitoring. We can either use fetal Doppler or a stethoscope. Now, this picture on the right is an example of a continuous electronic fetal heart rate monitoring. Electronic because we are using a machine, and this machine is connected to the mother's tummy by two electrodes that are attached, as you can see here, on the mother's abdomen. Now, for continuous electronic fetal heart rate monitoring, we have two types. We have the external, which we usually use or see nowadays in hospital setups in the delivery room. And we also have the internal type of electronic fetal monitoring. So how often do we have to evaluate fetal heart rate? Now, that depends on which stage of labor the patient is and whether the patient is a low-risk or a high-risk patient. Now, for example, if the patient is in a first stage of labor and she is just low-risk patient, then we have to evaluate and record the fetal heart rate every 30 minutes. However, if she's a high-risk patient at the first stage of labor, then we have to monitor or evaluate and record the fetal heart rate more often. That's like every 15 minutes instead of every 30 minutes. Now, if the patient is in the second stage of labor and she is a low-risk patient, then we evaluate and record the fetal heart rate every 15 minutes. However, if she's a high-risk patient, we have to evaluate and record the fetal heart rate more often. That's about every 5 minutes. Now, this concept of evaluating the fetal heart rate is the same whether we do intermittent auscultation or we do continuous electronic fetal monitoring. Now, this is how we report the findings for the electronic intrapartum fetal heart rate monitoring. These are the components. We have to report the baseline fetal heart rate, report the frequency and strength of contractions, report the variability, whether absent, minimal, moderate, or marked. Are there any accelerations? Are there any decelerations? And finally, we have to interpret by saying if it's category 1, 2, or 3. Now, we will discuss this one by one. Now, let's discuss first the baseline fetal heart rate. So, this is the mean fetal heart rate rounded to increments of 5 beats per minute during a 10-minute segment, excluding accelerations and decelerations. And the normal range for the baseline fetal heart rate will be between 110 to 160 beats per minute. Okay, so this is an example of a fetal heart rate tracing. Okay, so in the upper panel, we have the fetal heart rate. And in the lower panel, we have the uterine contractions. So let's first tackle baseline fetal heart rate. So as you can see here, this will be our baseline fetal heart rate. Okay, so the baseline fetal heart rate will be 150 to 160 beats per minute. Okay, so we use these numbers here as the basis of our measurement of the fetal heart rate. Okay, so we usually report fetal heart rate using a range of numbers. Okay, so for this case, it's 150 to 160 beats per minute. Okay, so we can also report the frequency and strength of contractions in this fetal tracing. Okay, now, for you to be able to determine the frequency of contractions, you have first to determine the settings by which this machine printed this tracing. So for this example, we have a tracing or a 3 centimeter per minute tracing, as you can see here. So what does that mean? It means that these 3 small squares, 1, 2, and 3 correspond to 1 minute. Okay? So this one column here represents 1 minute because it is comprised of 3 small squares. Okay? So when we are counting the contractions or the frequency of contractions, we have to count from the start or the beginning of the first contraction up to the start or the beginning of the second contraction. So this is how we count. So this is the beginning of the first contraction. This is 1 minute, 2 minutes, 3 minutes, 4 minutes, 5 minutes, 6 minutes, 7 minutes. So the contractions are coming in every 7 minutes. And how do we determine now the strength of the contraction? Now, to determine the strength of the contractions, we use these numbers. And we look at the peak. Okay? So for this contraction, the peak is almost at around 80. So this is moderate. Okay? Now, if the peak of the contraction reach only up to 40, that's mild. If the peak of the contraction reaches around 60 to 80, then that's a moderate contraction. And if the peak of the contraction reached 100, that is a strong contraction. Okay, for this strip, we have contractions that are coming in every 1, 2, so every 2 minutes, and the strength is moderate. The baseline fetal heart rate is about 150 to 160 beats per minute. So next is the variability. This is visually quantitated as the amplitude of peak to trough in beats per minute, and we have 4 types: absent, minimal, moderate, and marked. Absent variability is when the amplitude range is undetectable, almost like a straight line. Minimal variability is when the amplitude range is detectable, but it's 5 beats per minute or fewer. Moderate variability is an amplitude range of 6 to 25 beats per minute, and marked variability is an amplitude range with greater than 25 beats per minute. Moderate baseline variability reflects the oxygenation of the central nervous system and reliably predicts the absence of damaging degrees of hypoxia-induced metabolic acidemia at the time it is observed. In other words, among the 4 types of variability, it's the moderate baseline variability that we prefer. Other conditions potentially associated with minimal or absent variability include the fetal sleep cycle, arrhythmia, medications, extreme prematurity, congenital anomalies, or pre-existing neurologic injury. And this is a graphic illustration of the 4 types of variability that I already introduced. So this is absent variability. So as you can see, it's almost like a straight line. And this is minimal variability. This is moderate variability. And this is marked variability. Again, this is another representation of the 4 types of variability. Okay, so for acceleration, this is a visually apparent increase in the fetal heart rate from the baseline. The duration of acceleration is from the onset of initial change in fetal heart rate from the baseline to its return to baseline. Starting at 32 weeks AOG, acceleration should have a peak or acme of 15 beats per minute or more above baseline with duration of at least 15 seconds but less than 2 minutes. At less than 32 weeks AOG, acceleration should have a peak or an acme of 10 beats per minute or more above baseline with duration of at least 10 seconds but less than 2 minutes. Fetal heart rate accelerations are frequently associated with fetal movement, possibly as a result of stimulation of peripheral proprioceptors, increased catecholamine release, and autonomic stimulation of the heart. As with moderate baseline variability, fetal heart rate accelerations reliably predict the absence of damaging degrees of fetal hypoxia and fetal metabolic acidemia at the time they are observed. So in this example, this specific fetal tracing or strip, we assess the acceleration using this upper panel because this upper panel shows us the fetal heart rate. So as you can see here, we have an acceleration here and an acceleration here. So accelerations, as I've already mentioned, they are a transient increase from the baseline of greater than 15 beats per minute. So in this strip, this is the fetal heart rate. So we have three accelerations here. This is one acceleration, this is the second acceleration, and a third acceleration. So in this strip, we have two accelerations. Now for decelerations, these are visually apparent decrease in fetal heart rate from the baseline. So for accelerations, as I've already mentioned, these are an increase in the fetal heart rate from the baseline. So decelerations are the opposite. These are a decrease in fetal heart rate from the baseline. And we have three patterns: early, late, and variable. So among these three, early decelerations is non-pathologic because early decelerations usually denote head compression. On the other hand, late and variable decelerations usually are pathologic tracings, and usually late decelerations connote uteroplacental insufficiency, whereas variable decelerations usually connote cord compression. Early decelerations likely represent an autonomic response to changes in intracranial pressure and/or cerebral blood flow caused by intrapartum compression of the fetal head during a uterine contraction and maternal expulsive efforts. Early decelerations, like I said, are benign. They are not pathologic. They are not associated with an interruption of fetal oxygen, metabolic acidemia, or hypoxic ischemic neurologic injury. Late decelerations are fetal responses to transient hypoxemia during a uterine contraction. This is an interruption of the oxygen pathway to the fetus that can occur at multiple maternal levels in addition to uterine contractions such as the lungs, the heart, and vasculature. Fetal oxygenation is interrupted sufficiently to result in both severe hypoxemia and metabolic acidemia, and in turn direct myocardial depression and late decelerations. So after the contraction, fetal oxygenation is restored and autonomic reflexes subside and the fetal heart rate gradually returns to baseline. And here are the etiologies of late decelerations. There could be excessive uterine contractions, maternal hypotension, or maternal hypoxemia. There can also be reduced placental exchange, or as I've said, uteroplacental insufficiency, such as in conditions like hypertensive disorders, diabetes, intrauterine growth restriction, or abruptio. Variable decelerations reflect a fetal autonomic reflex response to a transient mechanical compression of the umbilical cord. Cord compression, with or without other sources of interrupted fetal oxygenation, may result in recurrent variable decelerations with absent or minimal variability and no accelerations. We also have a term called prolonged deceleration. So a prolonged deceleration reflects a fall in fetal heart rate by greater than 15 beats per minute, lasting more than 2 minutes but less than 10 minutes. And this is caused by the same physiologic mechanisms responsible for late or variable decelerations. However, the interruption of fetal oxygenation occurs for a longer period of time. If the fall in fetal heart rate lasts more than 10 minutes, then that is defined as a baseline change. We also have what we call a term sinusoidal pattern. And a sinusoidal pattern is a smooth sine wave-like undulating pattern in fetal heart rate baseline with a cycle frequency of 3 to 5 cycles per minute that persists for at least 20 minutes. This pattern is characterized by fluctuations in the fetal heart rate baseline that are regular amplitude and frequency. The sinusoidal pattern is associated with severe fetal anemia, although the pathophysiologic mechanism has not been elucidated. Okay, so as I've said, there are basically three types of deceleration: the early, variable, and the late. So in this picture, we are shown at an example of early deceleration. And note here how the nadir, or the lowest point of the deceleration, occurs at the same time as the peak of the uterine contraction. So what it means is that the lowest point of the early deceleration corresponds to the peak of the uterine contraction. So they're like mirror images of each other. Also note that the decrease of the curve is quite slow or smooth. Okay, so it means that from the onset of the deceleration up to the nadir or the lowest point is there is a elapsed time of greater than 30 seconds. Okay, so it is not an abrupt deceleration, it is a slow and smooth deceleration, like in this case. We also have a variable deceleration, and these decelerations may start before, during, or after a uterine contraction, meaning the occurrence of the deceleration has no specific timing or no specific pattern. For the late deceleration, this is a deceleration where the onset, nadir, and recovery of the deceleration occur respectively after the beginning, peak, and end of the contraction, meaning the nadir or the lowest point of the deceleration happens after the contraction or the uterine contraction. Okay, so this is a closer look at late deceleration. So late decelerations usually are gradual, meaning from the onset of the deceleration up to the nadir or the lowest point of the deceleration, there's an elapsed time of 30 seconds or more. So the decrease is gradual, smooth, or slow. Okay, so the nadir occurs after the peak of the uterine contractions, and the return to baseline also happens after the contraction. And these are early decelerations. As I've said, no, these are non-pathologic decelerations. Usually, this is due to head compression. And as you can see, the decelerations and the contractions look like mirror images of each other. And this is a variable deceleration. As you can see in this picture, there's no specific timing or pattern for the occurrence of the deceleration. And at the same time, there is an abrupt onset of the variable deceleration. So as you can see here, from the onset of the deceleration up to the nadir or the lowest point of the deceleration, the elapsed time is about 30 seconds or less. So that's what you call an abrupt fall of the curve or of the fetal heart rate. So that's one of the specific characteristic of a variable deceleration. So instead of a gradual fall in the curve or in the fetal heart rate, there's an abrupt fall. And this is an example of the variable deceleration. You can see here that the fall in the fetal heart rate is abrupt, and there's no specific timing as to when it occurs in relation to the contractions. And so finally, we have to give an interpretation to our findings for these fetal strips that we have. So we usually give our interpretation by saying if it's category 1, 2, or 3. Okay, so category 1 fetal heart rate pattern is normal, and this indicates minimal likelihood of significant metabolic acidemia and ongoing fetal hypoxic injury at the point that the strip was done. So the fetal status and fetal heart rate pattern may remain stable over time, or the fetal status may change, resulting in a category 2 or category 3 pattern. And for a category 1 fetal heart rate pattern, it has to have all of the following components. It should have a baseline fetal heart rate within 110 to 160 range. There should be a moderate fetal heart rate variability. There should be no late or variable decelerations. Early decelerations may or may not be present, and accelerations may or may not be present. For the category 3 fetal heart rate pattern, this is pathologic or abnormal. It is associated with an increased likelihood of severe hypoxia and metabolic acidemia at that point in time when we did the fetal heart rate tracing. A category 3 tracing has at least one of the following components, and these are absent variability with recurrent late decelerations, absent variability with recurrent variable decelerations, absent variability with bradycardia, and a sinusoidal pattern. Late decelerations and variable decelerations are considered recurrent when they occur with at least 50% of uterine contractions in a 20-minute window. Prompt evaluation, expeditious use of conservative measures to improve fetal oxygenation, and or expeditious delivery are indicated when a category 3 pattern is observed because fetal neonatal morbidity or mortality may occur if the pattern persists. So, what are some of the conservative measures to improve fetal oxygenation? Well, those measures include giving oxygen support for the mother. We can also position the mother in a left lateral decubitus position. And also, we can hydrate the patient. Category 2 fetal heart rate pattern includes all fetal heart rate patterns that are not classified as category 1 nor category 3. And because category 2 tracings may remain stable for a prolonged period of time, they have an uncertain prognosis and are quite common. Okay, so let's practice. So we are given this strip or this fetal tracing and we have to give a complete report. Okay, so first, as I've said, we have to determine the baseline fetal heart rate. So in this case, we have 140 to 150 beats per minute. Now, the contractions are moderate and coming in every 2 to 3 minutes. So that's 1, 2, 3. So that's contractions of every 2 to 3 minutes. There's minimal variability. There are no accelerations. And there are late deceleration. So interpretation for this strip is category 3. Another strip here we're given. So sorry for not too clear numbers here. So the baseline fetal heart rate for this strip is 130 to 140 beats per minute. The contractions are coming in every 1, 2, 3. So this is every 2 to 3 minutes and the strength is moderate. There's moderate variability. There are accelerations and there are no decelerations. So the category here or the interpretation is category 1. That's it for my lecture. Thank you for watching and please don't forget to subscribe in my YouTube channel and my WordPress site, Dokina Bigayne. Thank you.